This is my presentation on the musculoskeletal system and exam, as well as the abnormal finding of carpal tunnel. So to start off with the exam, it'll start with the introduction, as always, introducing who the provider is and explaining the appointment and explanation of the visit, encouraging any questions or conversations to help build rapport, reviewing the history of the present illness or the chief complaint. This can be done using the mnemonic old carts. Um, so some of the things that we are looking for in discussing the present illness is muscular or skeletal symptoms, injury, back pain. Like I said, the mnemonic old cart can be used to discuss the history of the present illness and to determine aggravating factors as well as alleviating factors if it could be associated to any trauma or injury, if medications are helping relieve pain at all, or anything that might be helping. Past medical history can include previous nerve, bone, or joint trauma or injury, joint or bone surgery, such as amputation or arthroscopy, chronic illnesses such as cancer, arthritis, osteoporosis, renal or neurological disorders, skeletal deformities. A family history can include any abnormalities such as hip or foot or back problems, any scoliosis, noting if they have arthritis such as rheumatoid arthritis or osteoarthritis, gout, rickets, any history of hypercalcemia or hypophosphatemia, any personal or social history. This can include employment such as repetitive motions like typing or lifting, chronic stress on joints, exercise, including if they do any weightlifting type of sports they perform, smoking or alcohol intake, and then functional activities, any weight gain or loss recently, height, and then the nutrition of the patient. So their calorie intake, if they have calcium, vitamin D, or protein in a day to day. The examination will start with inspection, inspecting and comparing extremities and skeletal for alignment, contour, symmetry, size, muscle, extremity, or joint or the size of the muscle, extremity, or joints, and just looking for any deformity, noting the posture of the patient, any kyphosis or scoliosis, inspecting the skin over the joints, noting color, swelling, masses, and then comparing muscles just to make sure that they're uniform in size and symmetry, and noting if there's any spasms. Palpation is next, which includes noting areas to the bones, joints, and surrounding muscles, noting the muscle tone, any warmth over the joints or tenderness and swelling, making sure to palpate any inflamed joints last, being careful of any discomfort that it might cause the patient. We are testing each major joint for active and passive range of motion, comparing it to the other side. Active range of motion can include having the patient move each joint through range of motion and showing you, and it can signify a problem if there's any pain or limitation within the range of motion. Passive range of motion is when the patient allows the provider to move the same joints and noting the end of the range of motion. And muscle tone can be performed at this time while doing passive range of motion. You test the muscle groups for strength and compare sides. With muscle strength, you contract the muscles by extending and flexing and resisting applied force. Expected findings are that the muscle strength would be equal bilaterally. Balance and gait is examined while watching the patient walk throughout the exam room, having the patient move from the chair to the exam table. You can also have the patient ambulate within the room, and posture also can be done throughout the assessment and examine how the patient holds themselves throughout. And then joints that deserve more focus can be your hands and wrists, elbows, shoulders, head, neck, spine, torso, hips, legs and knees, and then feet and ankles. And some things for carpal tunnel that we would want to examine would be the hands and wrists. And when we'd be inspecting, we would be inspecting the dorsum and palm of the hands, noting the contour, shape, position, and palpate the joints of the hands and wrist. And then we'd also have the patient flex at a 90 degrees and hyperextension to 30, form a fist, to thumb opposition, finger abduction and adduction, wrist extension and flexion, as well as hyperextension, radial and ulnar movement, and then testing the strength of the wrist extension and hyperextension and the grip strength of the hands. I've included an image that shows an example of how this would be performed with the patient.
Okay, so we're going to be assessing mobility and range of motion. So I'm going to have you stand up. Sorry, I know you sat down. So I'm watching how she got up, looking at the symmetry of her overall as she's standing. I'll have you raise your hands up and back down, and then we're going to raise them out to the side, back down, good. And then I'll have you put your head towards your chin, and then head towards the back of your neck, and then bring your one ear to your shoulder, ear to the other shoulder. Okay, I'm gonna have you turn your head like you're looking this way. Okay, and I'm feeling for resistance and turn the other way. Okay, shrug your shoulders for me. Good. I'll have you bend your elbows for me. Okay, and bring them back down. I'm gonna have you push up with your hands. Okay, good. And with your elbows kind of like this, I'll have you kind of push out. Good. And push in. Good. With your hands facing down, I'll have you push down on my hands, pull up on my hands. Good. And then we'll have you turn so you're facing that direction, and I'll have you bend down so like you're bending at your waist like a hinge, trying to touch your toes. Right now I'm looking at the back of your spine to make sure there's no kyphosis or scoliosis. That looks good. Go ahead and stand back up. I'm gonna have you bend back, opposite direction, good. And then go straight forward, bend to one side, and then to the other side. I'm gonna have you rotate, bringing your left arm over your body, and then back the other direction. Do you feel any pain with any of those movements?
No.
Okay, so then you can turn back this direction. Looking at your hands, I'll have you spread your fingers out, bring them back in, make a fist. Then with your hands out, you can do with your wrist up, wrist down, perfect. Typically, I would also have you sit down and I would look at your knees. With you having a recent injury with your meniscus and being treated for your knees, I'm not going to do that today, but I will have you sit down. With the patient lying down, you can also test the hips for mobility and flexion to identify any pain, but with her recent injury, we will not be doing that. So now I'm going to have you point your toes up towards the ceiling, point them down towards the floor, rotate your ankles for me, good. Other one, any pain with that?
No.
Okay, then I'm going to feel the back, feeling your muscles back here, good. I'm going to feel by your metatarsals, any pain or anything like that?
No.
Okay, and so we're just looking for, when we're looking at the skin, which we would do before having her do movement, we're looking for any bruising, redness, any joints that when you're feeling them, if they could be warm to the touch or red, any pain, and if we identify any painful areas, making sure we assess those last. And like I said, we're gonna not do the hips and the knees today with the recent injury, but typically you would see that done on a patient.
With the abnormal carpal tunnel syndrome, so what is carpal tunnel syndrome? It's caused by compression or pressure on the median nerve, and the carpal tunnel is a narrow passageway surrounded by bone and ligaments on the side of the hand. And when the median nerve is compressed, it can result in symptoms such as numbness, tingling, and weakness. So that's kind of the pathophysiology of it. Anything that could squeeze or irritate the median nerve can lead to carpal tunnel syndrome. And some of those possible causes can be mycotrauma, inflammation, edema, repetitive motion, or vibration in hands, with the risk factor of some things like anatomical factors, such as a fracture, dislocation, arthritis near the wrist. Sex, most often it's seen in women. Nerve damage conditions, diabetes could also create some nerve damage there. Inflammatory conditions such as rheumatoid arthritis, obesity, fluid retention can also increase the pressure, and this can be seen in pregnancy or menopause. And then Workplace, things like vibrating tools, typing, jackhammers, or repetitive flexion of the wrist. And it can be associated with rheumatoid arthritis, like we said, gout, acromegaly, and hypothyroidism. So, symptoms of carpal tunnel include numbness, burning, tingling in the hands or fingers, usually affecting the thumb, index, middle, or ring fingers. The sensation can travel from the wrist towards the arm or radiate towards the arm. It often occurs at night or when the wrist is flexed or extended, things like holding a phone, newspaper, or steering wheel. Objective findings that we see, the weakened thumb abduction, classic or probable CATS findings, which we'll discuss later, decreased pain sensation along the thumb and median nerve distribution, and then positive Tinel or Fallon maneuvers, which we will discuss in the following slides. This image kind of demonstrates where you would see carpal tunnel as well as helps display the median nerve and an imagery of that. So the cat's hand diagram. This is what you would have the patient fill out, and they will show you where they are experiencing symptoms of pain, numbness, and weakness. So it would be blank, and then this is an example of it being filled out with those areas. So classic pattern of this would be symptoms affecting at least two of the digits of the thumb, index finger, or long finger, which is the 1, 2, or 3 finger. Um, Permits symptoms into the fourth or fifth digits, possibly. It can include wrist pain and radiation of pain proximal to the rest, but it does not allow symptoms of the palm or dorsum of the hand. Probable pattern is the same symptoms of pain, numbness, tingling, and burning, but instead, palmar symptoms are allowed unless confined to the ulnar side. And then possible pattern would be involving symptoms with only one digit, so either the thumb, index finger, or long finger, and it may involve the dorsum of the hand. And then unlikely pattern would just be if there would be no symptoms affecting the 3 digits. And these were the tests that we talked about earlier that can also be used to diagnose carpal tunnel. The Fallon test is where you have the patient hold their wrists in a fully palmar flexed position with the dorsal surfaces pressed together for 1 minute. And numbness near the median nerve is suggestive of carpal tunnel. The Tinel test is done by striking the patient's wrist in with an index finger or middle finger where the median nerve passes under. And a tingling sensation from the wrist to the hand is a positive sign of carpal tunnel. The thumb abduction test is when you have the patient place their hand palm up and raise the thumb perpendicularly to it. You would apply downward pressure on the thumb to test the muscle strength. Full resistance to pressure is the expected finding. And then if you had weakness, that would be associated with carpal tunnel. You also can use an ultrasound to visualize the median nerve or neurophysiology testing or which would be like sensory motor testing of the median nerve. And then carpal tunnels likely with increased weakened thumb abduction, which we already mentioned, and classic or probable distribution on the cat's hand diagram, which we just talked about, and decreased pain along the thumb and median nerve. So with that, the Fallon and the Tinel tests are less accurate than the other findings, but it's just good to know as well. And so for treatment for this, early intervention, it could be taking frequent breaks, resting your hands, avoiding activities that worsen these symptoms of numbness, tingling, and then applying cold packs to help reduce any swelling that could be there. Non-surgical could include wrist splinting at night, NSAIDs, cortisone injections, and then surgical can either include an endoscopic or an open surgery. And these are my references.